Hello, good afternoon, everybody. Welcome to the 22nd episode of the Health System Fix podcast, and Happy New Year. My name is Gaurav Mishra. I'm a child, adolescent, and adult psychiatrist and a health systems design expert. Please like, subscribe, and share the podcast in your network. It helps support this work. I'm really excited today to welcome Clément Baissat. We just practiced his name, so I think I got it close enough. Clément is a bipolar mental health advocate and founder of HopeStage, which is a nonprofit created by and for people living with bipolarity. He's based in Sydney, Australia, where he's building peer support communities, building free tools, podcasts, and psychoeducation programs to help patients understand, navigate, and stabilize their daily lives. His mission is to make bipolarity less scary, more shared, and far better supported. So welcome, Clément. Great to have you.
Thanks, Gaurav. Yeah, happy to be here. And so quickly about me. So I'm bipolar type 2, and I've been having kind of a horrible experience as a patient. I think it's important to start a bit with my story. So I've been two started before. I had the depression twice. And one day in Paris, I was walking in the park and I was reading an article about bipolar disorder. And I called my mom, like telling her like what I found. And she started kind of crying. And she told me that my dad was bipolar. And and he didn't want me to know because it was a shame. And it felt like I was a little bit like, of course, mad. Of course, it was difficult to hear, but I was also really relieved. I felt that I finally understood like why I had like all those depression, why I had those I didn't know was hypomania. And then like 2 years later, I started HopeStage because I really felt like how can something this important could happen? And why the system is not better and why are we ashamed of being different? So yeah, a bit more context about why I'm doing what I'm doing.
Sounds like, there was a time that you were experiencing some of these symptoms, did not know what it was. So when you did first recognize this is what it is, at that point, did you start seeking care and what was that experience like?
Yeah, I think it's really important to be really transparent. So I found two different psychiatrists who actually diagnosed me because I kind of had the gut feeling when I knew my dad was bipolar. I was like, okay, maybe it's that. But then I wanted to have a like proper diagnosis. So I got the first one from a psychiatrist who was after about 10 minutes. She was like, hey, you're probably bipolar, take those pills. And I didn't really felt like trusting to take those pills. So I found a new psychiatrist. So I used my network. And then this time it was like about 30-minute consultation. And he just tell me like, okay, go and buy this book. And it felt much better because even if I needed to take meds, I needed some times to accept that. And so I started reading about bipolar, trying to understanding, and didn't want to take meds in the first few weeks. It's just after, I think 2 months, then I had like a little depression, like, and then I was okay, I need to take some meds. And it's not really a depression, more a depressive state, I would say. And then I was still unstable. Even with meds, I was having hypomania. I was learning about it, but I was still not wanting to let go hypomania because it feels good. I have to be totally honest there, and it took me a while to really stop like drinking alcohol. Almost, I drink like a glass of wine maybe once a month, but I'm not even drinking a full glass. It's more like to cheers with people, and like accepting that I will never smoke weed anymore in my life, accepting that even if my friend want to go clubbing, I can't go. It's not like I can't go, but I don't want to go. And I'm never say like never, because maybe once a year I'll be like, okay, let's do it. But it's more like accepting those change and then standing like, what are my triggers? What is going on? And then doing it myself and talking with other people, a lot of things really helped me, like talking to other bipolar. And and yeah, since I did two company before, I really want to do something about it. So I have like one company who is basically doing consulting to help labs, clinics in patient adoption. And that's what pays the bills. And on the other side, there's a non-for-profit who help bipolar people with content to understand and psychoeducation to accept and talking group. And yeah,
Okay. I think you described an important piece that sometimes in the medical community, it's too fast paced, and we are not taking into context what the patient's life experiences is. How are they feeling about you suddenly talking about this diagnosis with them, or not giving them time to even adapt? I think I like the approach of the second psychiatrist you mentioned, where he gave you some information, helped you get educated about it yourself. Sometimes we want to fix problems quickly, right? And we feel like, oh, this pill is going to solve everything. Of course, it does not, right? It is one part of the treatment. Can you tell us what book was that was recommended to you?
it's a French book. I think, yeah, the most important thing is to understand as a practitioner that says the science, and science is probably, yeah, it's really cool, it's beautiful, and as a psychiatrist. But I found the book is called Manuel du bipolar. So it's a French book, but Um, but it's also like what we found and what we're working on at HopeStage is about like what the patient believe and how do we perceive himself. Because whatever the psychiatrist is gonna know is gonna tell them is like if we don't believe we are different, if we don't believe we need pills or it's not gonna matter. It's not about truth. I like this example, which is this different type of truths. It's like from the book of Yuval Noah Harari, and basically explain like there's three types of truths. You have the objective truths. Let's say it's water. This is kind of objective. Even like a Martian coming today, if we accept physics, it will accept that it's water. Then there's like subjective truths, which is I like sparkling water, you don't, simple. And then intersubjective truth, which is in some country, like let's say you live in Iran, Israel maybe wouldn't exist because you have been taught at school that it doesn't exist. I was teaching in France and everybody thinks that Israel exists. But it's not like truth or not truth, weirdly enough, because if tomorrow a Martian come to Earth, the concept of Israel is not real. It's just a story that we're telling ourselves. It's not like physical, frontiers. It's just a concept that we made as human. And that's a simple type of truth, but just to understand that something as simple that we believe is maybe not believed by the other person. And the toughest thing, I think, for a practitioner, for a medical unit, is to understand that the way that as patient we understand and accept will usually take years. And it's it's difficult because you have the solution, you know what to do for the patient, but it will take years for him to actually do change, do talk about it with his friend, do change the way he work. And that's what we want to do at HopeStage and be the partner outside of the consultation to be like, there is a consultation, there's a medical part. We also work with, of course, psychiatrists, but most of all is like outside of it, you're going to go online, you're going to listen to content. You're going to be looking for talking group, for training, for psychoeducation, but what do you do and how can we repeat the same concept to you? How can you be able to talk with other people likewise? So little by little, by repetition, after months, after year, you will actually accept to what you have and why you're different.
It's interesting because there is a concept of insight that's taught within psychiatry. However, it's taught from a very, I would say in the old days, it was taught from a very, I'm the doctor, you're the patient perspective. oh, this patient has insight or this patient does not have insight, meaning they understand their illness and they know what it is or what it means, and even what they need to do about it. Like insight has a lot of meanings. And from what you're describing, healthcare may be great. They may be great at saying this person has insight or not, but they're not great at helping somebody get there, which is kind of what you're talking about. That's what you're trying to help people do, which is understand what's going on with them, not just because a doctor told you, but there are things in your life which you're struggling with and you can get help with.
Yeah, and it takes time. And one thing also that it really depends on the country. So now you live in the US, but for most of the experience that I had, it's like people sadly believe less and less at psychiatrists because maybe to tell a bit about my story, maybe I talked with 5 different psychiatrists before I got diagnosed. And I was always in depression phase. And every time since I'm 19 years old, I go to the psychiatrist. I get there. I explain a little bit what I had. They usually diagnose me with a depression. They give me some pills without me really understanding like what's the impact, why. And then I don't trust them. They were right. I was in depression. But yeah, why would I take pills? I don't understand the side effects. I don't understand like what can I change? And the most the most important thing for me is like they never told me to do something outside of the consultation. They never told me like, okay, maybe it's a depression, maybe you will need a treatment, maybe you can contact this non-for-profit, or you can talk with this talking group, or you can, I don't know, read this. And I'm just one piece of information for the person. It's only like, and it's tough because but if you want me to believe that I need to take my treatment, I need to have at least maybe 3 different person that I trust gonna tell me the same thing.
And at least let me start with even trusting you. If if a psychiatrist, any physician, any healthcare provider is talking to a patient, cannot build that relationship, but the person can actually trust where they're coming from. That is a gap, huge gap. And a lot of my colleagues will maybe disagree with me that I think we've gone too far in the direction of checklist-based healthcare and because of reimbursement models and funding models, and gone away from the human piece of healthcare, which is, in my opinion, I think the most important part of healthcare. More than the medication is a relationship building. Medication, of course, are important. They have different small and big roles in different illnesses or conditions, but the relationship is such a critical piece of healthcare, which is unfortunately is less seen today.
Yeah, and I think as psychiatrists, that's the way it is done. Reimbursement is done this way. But it's like either if you don't have the time as a practitioner, how can you find people who will have the time? That's that's a way to do it. And I'm not blaming psychiatrists because if I was in the same position as you, I'd probably do the same. But it's like, how do I work with other organizations? It's like, because if you are in a clinics, I guess it's a bit different. You have nurse, you have like psychologists. But if you are in a private practice, really think about what can I do to be part of a system? Because there's a lot of things happening. There's a lot of non-for-profits. There's a lot of even like company who are doing other services. And if I don't have the time to spend an hour, and most of psychiatrists don't have the time, maybe there's a peer helper who can do it. Maybe there's a talking group. So I think it's really like challenging the people to be like, how can I build a system around my patient? Because I'm only going to be there maybe once a month, once every 2 months for like 30 minutes. But what's going to happen in the rest of the time?
I think, it's a critical point because in the US also, there's obviously a lot more increase in peer support, even embedded within the medical model. However, in many situations, it's more lip service, as in saying we love it, please do it, not funding that model enough for it to actually happen. I'm curious to know about, so you were living in, I guess you grew up in France, and then you recently moved to Australia. What differences do you see, have you experienced in the health systems in the two places?
I would say, first of all, in Australia, you have to pay for services. So it's a big change because even if you can get reimbursements, every time you see someone, there's money going out of your pocket to pay for services. Every pills, everything. Where in France, we have like what is called carte vitale, and you don't feel the pain. So when you go into a pharmacy, you usually don't pay, or you maybe pay, but it's like €2 is like crazy low. So that's one thing. The price are much higher also in Australia. If you want to see a psychologist, it's like twice the price almost. There's also, I would say, I've been to the hospital because my girlfriend got a knee injury. So it's not a psychiatry hospital, but it was much more like secure, much faster. I think people also talk a little bit more openly about their mental health in Australia. I wouldn't say it's a perfect system, but I think long term it will work better than the French system because right now in France we had this dream, I would say, of free healthcare, which is paid by all their taxes. So it's not free, but like people don't have to spend money. But what we are seeing is the quality is going down. And in Australia, they choose a different path, which is they always ask the patient to pay a part of the treatment of the psychologist. And so the healthcare systems can stay at good quality. I kind of like the Australian system. I think it's a good in between the US and France. From what I know, in the US is like a bit too much, and in France is a bit too much the other way.
I mean, I think in the US, we fantasize about the nationalized health system as being the ultimate solution to all of the healthcare needs. And I think, obviously, you having lived there, see some of the gaps that even that system creates. So, no system is perfect, absolutely. Early in medical school, you don't want to talk about money, but eventually you understand money kind of drives all of the different things that are happening, and healthcare definitely. You understand that I think, like if you follow the incentive structure of money in nationalized or in private systems, it's probably will tell you where it's heading. Yeah.
Yeah, and the money is, at least from what I know, is going through hospitalization most of the time. That's where the money is where you get rehab, is where you get hospitalized because you're in crisis. And so in France, we actually went through the Congress, tried to pass a law and everything, but they changed the Congress, so it was like unlucky. But that's life. But yeah, like almost all the money is going through crisis. And so when we actually tried to get like some subvention for the psychoeducation program, and yeah, they wouldn't give any money. Like they would give money, but it was impossible. They were giving us like they wanted to follow everything that they want, the way their rules. You couldn't do it in certain places. It was only in poor places. It has to be physical. It has to be like 12 session with psychiatrist. And then they were like, okay, we're giving you €250. It doesn't work because we're all digital and there's volunteers everywhere. Psychiatrists have volunteers, PHAB are volunteers. So our cost per user is $100, I think, for a psychoeducation program with all the training and like the 150 lessons of exercise and the talking group and the live and everything. But even that, we couldn't get it. And on the other side, you have clinics, you have hospital. They will give them like €1,000 a day for hospitalization. It will take maybe 30 days, to simplify. So they will give them $30,000 for one person. And we know from the study that some psychiatrists have made in the past, because they have studied psychoeducation, and that's why we work with them and partner with them, that we can reduce hospitalization by about 40%. So you give us $100, the way the system is built. And administration, the one that we're seeing, the cost of actually getting this $100, if we can, is like, and it's why I'm doing consulting now, because it's better to find a customer that pay for consulting service that has it's a different thing than actually finding money from the government. Because the way it's built, you have to be a clinic, you have to be a hospital, if you're not that, you're not checking that box. And so, yeah, it's a bit frustrating. You can feel it in my voice.
I'll tell you the American it's very similar, by the way. You'd not expect it, but it's very similar. In the American system, all of the money is being pumped into the immediate crisis intervention. So when somebody has let's say they are very sick, they have a psychotic break, something like that, they're in the community, and then transporting them to the ER and getting some intervention quickly within 24 hours, that piece of it is funded better than the inpatient. So the long-term inpatient stays are very rare in the US today. I've had patients who are suicidal, go to the hospital and be discharged in 6 hours. That's a reality. So even patients who do need to stay a few days, 1 or 2 weeks in the hospital for their recovery, that's less common today in the US. Whereas at the same time, the problem of not funding upfront investment to prevention, psychoeducation, all of that is very low funding in the US too. So primary care is weakened because primary care docs have to see 24, 25 patients a day, 30 patients a day, in which you're spending 5 to 7 minutes of your time to talk to a patient. There's no way you can take care of the whole body and mental health in that time. So I would have thought in a nationalized health system, there'd be a lot of upfront investment of prevention. And I'm guessing you don't see that either.
It's like it was the case in the past. So to go back a little bit in the French system, I think it's really interesting because so in the year, let's say 2000, what was happening is France was way richer. Let's be clear. And so we were pumping much more money into the system. And also on the other side, most of the people working the system were really in the sort of like bubble. So they didn't have much, like, you need to see X amount of patients. It was like, okay, you pay your full time, you do what you think is the best to help the patient. We're not going to control everything. And if you want to go out to the beach with 10 patients, you just go out to the beach and you do your thing. And so people, they were having a lot of funding and they were doing what they want. And so there were no carrots. So they couldn't get more money. So they wouldn't get like bonuses. But there was no stick also. So if they wanted to go to the beach, they could do it. And what we did in about 2009, just after the crisis, is like we start using the stick, but no carrots. So we basically say, okay, you have to see 25 patients a day. You have to, but we didn't give the carrots like, if you do that, we give you bonuses. So what happened is the system started to collapse because why would you work in the public environment where you have a stick but no carrots, where you could be paid better in the private sector and have your carrots? And also we put less money per patient, and then the system started to go down. So it's like, I would say that my perfect system personally is, and it's kind of weird, but I think people should pay based on their age. And that's probably the simplest system, is because sadly, is like, you don't have money for everyone. So, and if you are like 5 years old, 10 years old, you pay 5% out of your pocket. So it's really kind of basic. I think it needs to be tested. But if you're 20 years old, you pay 20% of your pocket. If you are like 70 years old, you pay 70% out of your pocket. And it's, if you invest in young people, is like usually save more money afterwards. And And that's the way it is. Like, you don't have enough money for everyone. You have to make choice. It's quite sad. It's what I would like to do is you need to make people pay, because if it's free, it's not good. But making them pay 100% is like, if you're young, it's like you're not going to take care of yourself, and it's only going to get worse.
I'll tell you, I see some problems in your ideal situation because, but if we are a clinic and a 5-year-old only pays 5%, I'm incentivized to not see as many 5-year-olds.
Okay, so what I'm saying is, because I'm thinking still in the French way. In the French way, basically, you get, like, as a clinic, the government is going to pay the rest. So if you see a 5 years old, the government is going to pay 95%. So it's because, okay, that's because it's the way I'm thinking the French way.
But also, I would add your poverty level status, because I think in that mix matrix of age, but also your economic status and ability to pay. We are living in, and I'm sure Sydney has the same situation, some similar situations. I'm living in San Diego, a first world wealthy city, but there are a lot of patients who live paycheck to paycheck who do not have ability to spend on healthcare. And I think by not subsidizing their healthcare when they really need it, you're kind of the disease burden, economic burden on the system also increases over time. I think the best system, if you're talking about let's invest in prevention, let's invest in psychoeducation, absolutely true. But that has, I think, maybe 5-10 year runway where you have to do heavy investment for a few years, and maybe a half a generation later, then you start seeing the economic return. So it is very heavy in early investment, which is needed, I think, for that system to work well.
No, I do agree. The things that I present is more like based on the French system, because if you do that in the French system, meaning you will, like, get a lot of money that you can actually invest. Because I've seen, like, prime minister and those people, and they they say they want to invest, but they won't invest.
By the way, like a lot of healthcare CEOs will say, "Oh, we mental health is such an important part, but nobody wants to pay for it. Nobody wants to invest money in it." So unfortunately, in the past, and I think probably today too, when you go through medical school, medical training, you are given a huge amount of confidence, real or unreal, into your opinion and what you think and how you think. And there is not a lot of teaching of let's partner with the patient, at least back when I was training. And I think some of it exists today too. And so, however, what that does is to a young trainee, to a young physician, that makes us think, or makes people think, oh, like I know what's right and what is needed. That approach of let me tell you what is needed for your care. And however, as you keep working over time, then you get to a point you realize, oh, okay, medication and my diagnosis is only a small portion of this whole person's life, and it has a small role. And you already are on this journey. What is the unique perspective that people like you with lived experience, what can they bring to the health system? And that makes us change how we are doing things today.
What I've found is, when you're patient, to find your path to, let's say, rehabilitation stability, helping others in this path is really good. Because when you learn something, when you accept something, and spending a bit of time, and it won't be forever, but um, it really helps you, like, being an example, being proud of yourself, and just giving someone a little bump on this journey. And what we found is, after usually a few years, you want to put it aside and you want to work on something else. But I think there's things to be built on how can someone find their path to help him learn. And it's why we love psychoeducation, because what we've seen is someone who go into the program at the end of the psychoeducation, most of the time, they want to be the one animated the talking group, because they want to give back, and then it will help them, like, really understand what they need. So that's one thing I think would be great. On the other side, I would say that it's like everybody needs to build their own system, and it's the patient who's going to do it. And that's the toughest part. And and I think that I s- I think most people believe now, most people that I talk to, but it's like the psychiatrist is a part of the system, and you are probably one of the most essential part, because then there's treatment also. But how the patient is going to build the system using you, around you, and accepting, I think also for the psychiatrist, that you're just you're an ace, but you're only one card at the end.
I think that's very well put, because I think this job of the psychiatrist in the situation is that when you're first encountering severe illness, you may have a little bit of a bigger role to help this person get to a place of being a little more stable and feeling better. But long term, you want to be a very small piece in that circle of support that on and the network that they have built. You and I've realized this well with a lot of patients I see, as they do better and better, my role becomes smaller and smaller, which is a good thing. And it's great that they have this other full life, which they need some support in one part of their life, and I can do that for them. But there's a lot of other things they need, and hopefully you can get them there with to get to the full life experience, not just, oh, let's fix the diagnosis approach. Let's help you figure out everything else also, where I think, of course, peers really help with that. Tell me a little bit more about Hope Stage, and what's your long-term big picture, like, goal with Hope Stage?
So, um, my dream is to help bipolar people, because I think like it's not costly actually to build what we built, and the impact it has on people is like beautiful. But it takes years. That's the toughest part. But you see people being alcoholic, without job, just stopping alcohol, finding a job, finding a girlfriend, and just get their life back together. And it's because they have interaction with upstage, maybe even more than once a day. It's because we're repeating the same message over and over again. And what we're doing is we're competing with Netflix, we're competing with TikTok, whatever, because everybody wants to get attention. And so our dream is that any bipolar person anywhere in the world can found like information to help him understand, and a psychoeducation track with talking group to help him accept. And this part, it's my dream. But to do this dream, um of course we have support, we have donation, but I'm not really confident into like the being dependent, because I've seen what happened when you're dependent with the government. If the government change, then you're lost. And so that's why we have consulting company aside. So what we do is we help clinics, labs to understand how to talk to patient and to improve patient adoption. Because over the year, I've met like 100 of great projects that have really good science and can help people with mood disorder. But they have the science, but they don't know how to bring the gap and actually get patient to use their services, because they are talking to institutions, they're talking to psychiatrists most of their days, but they're not talking to patients. And so the patient, when we go into a solution, we have fear, we have doubt, we're emotional, we're not rational. And so we do not make decision to use something based on science. Sadly, I wish it would be. And so it's really about like helping them diagnose the way they do it, understand what is their persona, doing focus group, what are the wording, and then really how to communicate, how to create content, how to create like things so the patient will actually adopt their services, like get testimonials, this type of thing. And so it's really like two sides. Depending on how it goes, I will focus more my time on one or the others. But Yeah, basically is like helping like good science meet patients and making every patient be able to have like a free education system.
Right. I think actually what you pointed out is very critical that in healthcare, you may have the most brilliant idea, but the implementation is the key. How you implement something makes the difference, whether this amazing new technology or resource is actually going to get adopted. And I'll say the resistance is as much with the health system and the professionals and the psychiatrists. I'm sure you've encountered that you may come up with this amazing proposal. I'll do this for free or support your patients. Even then, adoption is not easy. There's a lot of difficulty in adoption. So I think it's critical how this is embedded in health systems and how health systems themselves adopt it. Because it also, a lot of times the patients go to the health system with a sense of trust that, okay, when this person is recommending, maybe that's important, I should do it. But yeah, it is adoption within the health system to use it for patients is also not an easy task.
Yeah, I agree. And something that, of course, there's a health system, but we have to understand that in 2026, people will get information from social media, from AI, from internet, and the word has changed. And and it's of course, even if your doctor is telling you to do something, it's just one piece of information. And so it's why I really believe, and it's difficult to do because you have to sell, you have to not sell your product. You have to sell uh, the emotion that the person want to feel. And it's weird because it's like I love science, and most of the great technologies that I found are usually the product that works the less. It's really horrible, and this is because people are scared and they're not seeking rationally.
The thing about the emotion piece is critical even in health systems. So if when you're approaching a health system that we want to support with peers, we want to support with psychoeducation, even there, the approach needs to be, I'm going to solve a problem for you, the psychiatrist, by taking this important piece of healthcare, which currently your system doesn't support, which is psychoeducation and peer. I'm going to take this off your hand. And trust me, it's a huge emotional, mental stress reliever for the medical team themselves, let alone the patient. It's a giant support system. So I think you're right. You have to actually talk about how does this service, yes, help the patient, but it also helps the health system, reduces burnout in professionals, reduces doctors and psychiatrists leaving the health system, which is common. So it really has a lot of positives beyond the obvious one, which is help the patient.
And something that I've found also is you have to convince the health system for sure, the psychiatrists. But this is one of the things they are spending a lot of time on, but they're not spending much time talking to patient directly, but not patient who are healed, but patient who are like already like having sort of critical point of view with being like stable. And that's what we do. Like all the people we work with, all the consultants are bipolar themselves because the way we want to challenge the device is like, okay, I'm rational. I'm not here in a way. I'm not like destabilized, but I'm going to talk to you not as a patient, but as an expert in communicating into your product. So that's what we are building because I think like if they can tweak this, the adoption will raise. And if adoption raise, then everything change for them.
I'm thinking about a few of my patients who have bipolar disorder. And when they first started working with me, they were not stable, they were not doing well, but they had been working, so they had to leave work and focus on the treatment. And when they got better and they were eager to go back to work. And at that point, based on my training, my recommendation was don't rush back to full-time work, ease into it so that you have bandwidth for yourself to care for yourself and your mental health. For anybody who may not even have bipolar, for them, work and balancing that and balancing stress and taking care of your health and mental health is a challenge. To me, that seems that somebody who has a higher vulnerability to get sick with bipolar disorder or other illness, they have to be a little more careful. And sometimes I think, am I being patronizing? Am I giving them advice about their life that they don't want to hear from me? Or do you think that is the right approach? How do you think about that?
I think, as you know, every patient is different, and some people will want to have that, some people won't. But I believe that if you say it, it's because you believe that it was the right thing to say. I think the most important is just remembering that you are one person, and it will have to have their wives, their children to tell them the same if they actually act on it. So I think it's one of the things also that is probably really undervalued is, and it's not done properly in the health system. It's like, how do you communicate also with the yeah, with the loved one? And I haven't found a proper way to do it. So we have a lot of parents, a lot of brothers, sisters who go to our website to understand. It's one thing it'd be interesting to work on. I believe a lot into, of course, AI, because some of the things that were impossible could be possible now, but how can we do it properly? I believe a lot, for example, into recording conversation with your psychiatrist and having like this data set to help you actually have a message, for example, tailored for the loved one, things to help you remember what happened into the consultation. Because what I felt is when you're going to a consultation as a patient, your psychiatrist will take note, but you won't. And you go out and you forget, let's say, 70% of what you just hear. So how can you help the patient remember and memorize what's happening? And how can you also let know the loved one? So I think that's why like it's the first step to record, and how to use this, it's another question.
Yeah, I mean, now with ambient AI, which is, I don't know if you're aware of the technology, AI companies are launching recording devices within the exam room, office of the psychiatrist and all medical professionals. It captures everything spoken by every team member and the patient, right? And it puts it together in a nice summary clinical note before the session is done, and the provider just has to sign. It's a huge burden reducer for like reduces significant burden for work for the clinical team. But maybe, maybe eventually a copy of that recording goes to the patient too. Let me ask you a last couple questions here. What is the most exciting or challenging problem you're working on today? It could be in your consulting.
I think right now is helping tech go to have patient adoption and having them to understand like what it is to work with a patient and how can they improve that. Because I think I have to be honest, the non-for-profit, it will take years. And we've seen it, I don't know, we have 20, 30% growth over year every year. It was much stronger at the beginning, but now it's slower, which is noble. But it will take time. But right now, I don't want to go into medical device. I don't want to, because I I don't think I have the patience to wait like 5 years, 10 years to get reimbursement and everything. And so it's helping people do that and do it knowing what the patient feel emotionally and how to connect with them and how to improve the patient experience too. I haven't done it enough, but I would love to work on that. And that's typically the type of technology that already exists. And they probably have a great technology. But if we can work with them to help them understand a little bit the other side of the room, and or not only the psychiatrist, because the psychiatrist is the one paying for it. Because every time in every medical device, most of the time, is either the insurance, social security, or the psychiatrist that pay for it. It's almost never the patient. It is the patient sometimes, but you know what I mean.
I I agree with you. That's exactly how it's set up.
And so, but at the end of the day, we are using the services. And so the patient experience, it could be improved so much. I've seen it almost every time, but it takes a while. It takes, but to really understand, like, but that's the thing I want to work on.
Okay, the last question I had, if you had an advice for anybody who's struggling with bipolarity and has not found the right treatment yet, what advice would you have for them?
It's pretty about learning. So we're called HopeStage, and there will be a way. And you could have like so much disappointment, so much failure, but there's like so many great device, so many solutions, then it's really about keeping the belief and keep learning and keep trying. It's quite simple, but I think that's the most important, and not say that it's because a psychiatrist didn't work, it's because treatment didn't work, that it won't work another time. And I know it's tough. I've been there, I'm still there, but you're gonna make it. Just and maybe the one last thing, which is what you need to know, is ask for help. That's the most important thing to accept. So we're talking about understanding and accepting, but accepting that we need help and we need to ask for help. And if you do that, and if you keep believing and hoping, it will be fine. You'll find it.
And unfortunately, in many cultures, asking for help sometimes is seen as a sign of weakness, but I think it's a biggest sign of strength because you're recognizing that you need help. And I think even if you're somebody who's a helper by nature and that's what you think, I'm going to help other people, it's okay to ask for help yourself. Thank you so much for joining us today. I think it's a pleasure talking to you, and I wish you well and wish Hope Stage well too.
Thanks a lot, Gaurav. It was awesome talking also. And yeah, I wish you a happy new year and great health.